Today we're going to talk about the ovary. I just want to say a brief hello again, and some of you may know that I recently moved to Georgetown or to Washington, D.C., beautiful city. We see Thomas Jefferson, and this is actually where I work now in Georgetown University Hospital. It's on the campus of a beautiful university. This is part of the university, one of the buildings. And Georgetown, if you've not visited it, is a very special place. It's obviously in our nation's capital. A lot of people live in these beautiful big homes. I'm lucky I could afford something a little more modest, as we see here, and I'm having a great time in Washington, D.C. Before I was in Georgetown, I worked in Boston for 18 years, where I was up at Harvard, and some of you may recognize this logo from Harvard, very formal, very fancy. So I thought when I went to Georgetown, I should replace it with an equally beautiful logo from Georgetown University Hospital. So I went searching, and the best I could come up with was Jack the Bulldog, who is a very big favorite on the campus of this university. So I urge you, if you can, come and visit us. So today we're going to talk about ultrasound of the ovary, whether or not we should worry. Of course, we want to feel secure as we're doing our imaging, not feel that we are hanging on for dear life by our fingertips, and we'd like to be up here with our friends. Fortunately, most women who we examine have normal ovaries, and here we have the sort of index appearance to an ovary with a beautiful ovoid shape, small peripheral follicles, and this is what we would love to see in all patients. But we know that not uncommonly things happen in the ovary. And it's very important that we are able to recognize things that happen to the ovary that are either worrisome or, as in the majority of patients, the great majority, things that are not worrisome. And we're going to stress this in the discussion that we are going to have in the next few minutes. Of course, sometimes we see things in the ovary that are clearly disturbing, as in this nice diagram or schematic seen. All of these come, by the way, from Dr. Netter and his group, Frank Netter, to which I want to give a big thank you. So it's very important when we're starting to do our scans. We typically begin our abdominal scans. We begin with an abdominal scan and then often go to a vaginal scan to know the patient's history. Now, this woman came in, clearly had a palpable mass on more than a single occasion. And I think it's very easy when you look at a scan like this to say, you don't see anything significant. There's a little bit of fluid in the pelvis here, which is not uncommonly seen and is not necessarily a problem. But what is more difficult in this case is to realize that that is not the bladder. That is an ovarian cyst that mimics the bladder. As a matter of fact, there is the bladder. In this patient, it's not well distended. So how do you find that you don't get yourself in trouble? Because to miss a 10-centimeter ovarian cyst for a sonologist would truly be in an embarrassing situation. The first thing I'd like to stress is to know the history of the patient. If somebody consistently feels a mass and you're only seeing one ovary, you don't see an ovary on that side, be concerned that perhaps you're dealing with a mimicker for the bladder, in which case this would be the ovarian cyst. The second thing is, if I was doing a scan like this, I'd say to the woman, now empty your bladder, I'm going to do a vaginal scan. But she'll tell you that she just did empty her bladder and it's empty. So there's a mismatch here. You could get out of this problem and solve it in several ways. One is you could ask the woman to drink a lot of water to try to fill up her bladder, make sure this isn't the bladder. You could also put a Foley catheter in. But what I like to do is when I'm doing my vaginal scan, every time I put the transducer in, I can see the urethra. And the urethra, of course, is a landmark because it will connect to the bladder. And you'll quickly recognize this to be the bladder and that to be separate from it. And so there's nothing intrusive to the patient in terms of discomfort like a Foley catheter or discomforting like filling her bladder to get it very distended. So I urge you to remember this case. Be aware of mimickers. There are many others that you can see, as we see here, being pointed to by the various arrows. And what these are, in these particular cases, we're dealing with bowel, vessels, and even fibroids that can mimic the ovary. So how do you obviate the problems here? One is a real-time scan is certainly a good way to bail yourself out, because bowel should peristall. So if you compress it with the probe, you'll see that bowel will compress, and maybe you'll start peristalsis. Vessels, you could either put color flow on, as we see here, but typically these are small veins that have flow in them. And if you were to just turn up your gain setting, you will see the slow flow, the echoes move slowly within these veins. And also, of course, you can compress them with the probe, similar to how you do a DVT study, compressing the veins. So the main thing is to recognize that this isn't the ovary, and sometimes these veins can mimic follicles. So be aware of this and solve the situation, go elsewhere, look for the vessel, look for the ovary. Now this case is probably the most problematic because I think it really does look like an ovary. But you can see I'm taking the probe and I'm blotting by the uterus, and this structure sticks with the uterus. Therefore, it's part of the uterus, and therefore it would be a subserosal fibroid. So once you recognize this, take your picture and then move elsewhere to find the ovary. Now, I begin all my scans transabdominally, as I showed you in the initial case with that pseudo-ovary, pseudo-bladder due to the ovary. Here's another example, big mass in the pelvis, which would most likely be a fibroid, which is what it is. But the question is at this point, can I find an ovary? And many people give up very quickly saying, I'll never find an ovary with such a big mass, as in this case with a big fibroid. And I would like to urge you not to have this attitude, because when there's a big mass in the pelvis, the ovary typically goes in one of two places. One is it's moved superior to the side, so lateral, and superficial. So that's up, out, and superficial. Or if it's not there, it may be located deep in the pelvis. So what I would do at this point is change my transducer to one that could see better superficially, and I'd go looking for the ovary. So in this case, we changed to a curved probe, a higher megahertz, this being 6, the other being 4. Harmonics is on to get rid of the noise. You can compress with this probe, and sure enough, we see 2 normal appearing ovaries. And at this point, the study is probably finished, because you're not going to see this uterus better with a vaginal scan. Had I not seen the ovaries, however, I would have proceeded to do a vaginal scan to see if I could find the ovaries deep in the cul-de-sac. But the main thing, or in the pelvis, the main thing I would like to stress is don't give up and say I can't find the ovaries in a patient who has a large pelvic mass, because you will be rewarded if you know where and how to find them. Now, what I'd like to focus a large part of this lecture on is an approach to women who have cysts in their ovary, because most things that happen to the ovary are cystic. And I would like to suggest that if you have one of these 6 conditions, which I will call the big 6, they're all common, benign, and recognizable, you are going to be able to see at least 90 to 95% of the conditions that affect the ovaries, and you'll know what to do with them. And this is obviously important because in this situation, all of these conditions are benign.